Welcome to Autoimmunity. And this is where I think immunology is already interesting, but the hypersensitivity and autoimmune chapters um, really get interesting for me. So we need to define autoimmunity. And autoimmune diseases are conditions in which damage to organs or tissues results from the presence of autoantibodies or autoreactive cells. So this means that you're making antibodies that react to your own cells or tissues. And this is thought to be caused by the loss or breakdown of self-tolerance brought on by several different mechanisms, including deletion of certain genes or effector cells and active regulation by T cells. So another thing that could cause autoimmunity is a sequestered antigen. So think about if you are have a brain trauma, and so all of a sudden you have some brain exposed from a trauma. That's going to leave open a new area to circulation that maybe your immune system has never come in contact with before. And then there's also something called molecular mimicry, where you can have bacterial or viral antigens that resemble self-antigens. So they kind of look alike. So bacteria or viruses can look somewhat like your own cells or tissue, the antigens anyway. Okay, so the causes or etiology of autoimmune diseases, there are several different causes that we know of or that we have discovered. Defects in the immune system is one, so a loss of T suppressor cells, natural killer cells, cytokine production, phagocytosis, and complement components. So this means there can be defects in any one of these, like a defect in natural killer cells, phagocytosis, and later on we're going to learn about different very specific problems that can arise with phagocytosis. The influence of hormones. Estrogen affects cytokine production. So women have more estrogen, and so they are more prone to autoimmune disease. And hormones also suppress T cell regulation. Environmental conditions and genetic predisposition can all contribute to defects in the immune system. Autoimmune diseases can be classified as systemic, like throughout the whole body, or organ specific. And usually there's some overlap because diseases that start out as organ specific can later affect other organs. So there's a list in your book on table 14.1, at least in this edition that we're using in 2020. Now we're going to start talking about specific autoimmune diseases, and the first big one that we're going to talk about is lupus, systemic lupus erythematosus, or SLE, but we just call it lupus. Lupus is a chronic systemic inflammatory disease, so it's all over the body. And it alternates between flare-ups and remissions. So the immune response is directed against a whole broad range of target antigens. And typically the patient has 3 circulating autoantibodies. So think about it, 3 autoantibodies that are attacking themselves. And it's thought to have genetic and environmental links. Lupus affects 1 in every 2,000 people. The incidence has tripled in the last 40 years. The peak onset of age is between 20 and 40, so that's a pretty wide range of onset. It affects more women than men. And there's a high titer of anti-Smith, and it's notated anti-SM, anti-Smith antibody. The HLA, along with 13 other chromosome regions, are involved. That's not so important. It can be drug-induced, and if it's drug-induced, when you take away the drug that the patient is on, then it can go away. Then environmental factors include exposure to ultraviolet light and infectious agents like bacteria and viruses. The clinical signs of lupus are really very diverse. There are non-specific symptoms like fatigue, weight loss, malaise, fever, anorexia often are first to appear. Joint involvement seems to be the most frequently reported manifestation. and it presents as a symmetric arthritis that involves the joints of the hands, wrist, and knees. But it's important to note that no one's symptoms are the same, so not every patient will have the same symptoms, but definitely note this might be a test question: joint involvement, symmetric arthritis. After joint involvement, the next most common signs are skin manifestations, and the classic sign is the butterfly rash across the nose and cheeks that can develop. And this is what is responsible for the name lupus, because in Latin that term means wolf-like. 1/2 to 2/3 of all patients exhibit renal involvement, so that's usually the cause of death is renal failure. That's the most frequent cause of death, and it's because these immune complexes are depositing in the kidneys, in particular the glomerulonephritis. So renal failure, most common cause of death in patients with lupus. And here's a nice concise list of the symptoms. Remember, because no one's symptoms are the same, you can have the malar rash, that's the butterfly rash, a discoid rash, sensitivity to light, oral ulcers, arthritis, serositis, renal disorders, neurological problems, blood disorders, immunologic disorders, okay, and the presence of anti-nuclear antibodies. The first clue in the mystery of lupus was the discovery of the LE cell. And the LE cell is a neutrophil that has engulfed the antibody-coated nucleus of another neutrophil. And this is mainly seen in vitro, but that's what an LE cell is, and you need to remember that forever. Next was the discovery that lupus is associated with more than 25 autoantibodies. So I already said that most patients have at least 3. There can be up to 25. Lupus, just like we said, more than 25 autoantibodies are possible. Some are more common than others. And the immunologic findings, there will be overactive B cells. Well, that makes total sense, right? Because B cells make antibodies, so they're overactive. And complement activation, because you have all these antibodies being spit out that can coat cells, and that's going to activate complement. The only constant presence of antigenic material triggers polyclonal activation of B cells. This is really the important part here, is that immune complexes plus complement are formed and can't be cleared, and so they're deposited in the glomerular basement membrane, which leads to kidney or renal failure. So remember, immune complexes, that means IgG complexes, plus complement activation, complement cascade activation, immune complexes deposited in the kidneys, renal failure, it can lead to death. Drug-induced lupus differs from the more chronic form because once you take away the drug, the symptoms disappear. And when lupus is first suspected, the first test typically done is the anti-nuclear antibodies, or ANA. That's important. You need to remember that. The screening test done for lupus, the first screening test is ANA, anti-nuclear antibody, and it's a pretty fun test to do. So fluorescent anti-nuclear antibody, or FANA, we don't call it that, we just call it ANAs, but it is a fluorescent indirect method. It's the most widely used test because it detects such a wide range of antibodies and is positive in about 95% of patients with lupus. So here are the takeaways for this slide that's really important. ANA, or FANA is how it'll be listed on your test, is the screening test for lupus. But ANA has a low specificity, which means you get a lot of false positives. So that's the downside. Okay, so these anti-nuclear antibodies are extremely sensitive. They're easy to perform, but there's low specificity. 5% of lupus patients test negative. So look at that. So just because you have lupus doesn't mean that your ANA will be positive 100% of the time. and 2% of healthy patients test positive. So that means that 2% of the population, like if we tested 10 of us students and we're healthy, that 2 of us could test positive for lupus and we don't have lupus. And 75% of elderly patients test positive. So that's not too good either. So now it's common practice to screen with a dilution of 1 to 80. So a patient is considered positive if they have a 1 to 80 titer, or if they're over 65, they need to have fluorescence at a 1 to 160 dilution to avoid low positives in the normal population. So let me show you what I'm talking about. You would actually make a serial dilution with your patient serum samples. These cells, these microscope slides, come already coated with, it could be like mouse kidney or different kind of cells. Then you incubate it with the patient's serum, and then you would wash that off, and then you would add a fluorescent label that would bind to that patient. So antibodies to double-stranded DNA, which can be one of the antibodies, autoantibodies. So that means your body can make antibodies to your own double-stranded DNA. Just think about that. So now that as we get further deeper into immunology, it feels like a miracle that we are all walking around healthy and aren't sick all the time, because just think about all these little parts to our immune system. I mean, we've talked about the cells already, but now we know about the 30 different complement components. It's just, it's amazing. Okay, so you need to know the autoantibody and associated patterns and diseases on table 14.2 on page 215 of your book. And there's a better picture toward the end of the lecture. But going back to the titers, so this would, for a patient to be positive if they were over 65, we would have to have this level of fluorescence at a 1 to 160 dilution. That's what that means. All right, double-stranded DNA antibodies are the most specific for lupus because they are mainly seen in patients with lupus, and the levels correlate with the activity of the disease. So when these antibodies are found, it is considered diagnostic for lupus. So double-stranded DNA autoantibodies are considered diagnostic for lupus, especially when they're found in combination with low levels of C3. And the anti-double-stranded DNA pattern is homogeneous. So that means the whole cell will be fluorescent green. So this is very important. Double-stranded DNA, the anti-double-stranded DNA pattern is homogeneous for ANAs, and it looks like this. A second major antibody found in lupus patients is the anti-histone antibody. So a histone is the protein that chromatin wraps around to make chromosomes. So your body can even make a protein to the antibody to the protein that your DNA is wrapped around. I mean, that's just crazy. So the presence of this anti-histone antibody alone or combined with the antibody to single-stranded DNA supports the diagnosis of drug-induced lupus. So very interesting. Anti-histone antibodies are also found in rheumatoid arthritis and some other diseases. But the takeaway here is just that your body can make antibodies to so many different parts. It's just crazy. Antibodies are also stimulated by DNA complex to histone known as deoxyribonucleoprotein. You don't need to know that. You do need to know that the anti-histone complex ANA pattern is also homogeneous, like double-stranded DNA. Antibody to a preparation of extractable nuclear antigens was first described in a patient named Smith. So we get the anti-Smith antibody. The anti-Smith antibody is also specific for lupus because it is not found in other autoimmune diseases. And the pattern for anti-Smith antibody pattern will be speckled. And this gets a little tricky because you can have coarsely speckled and finely speckled patterns, but for right now, we're just going to know that anti-Smith antibody pattern is speckled. Okay, this antibody, the anti-Smith, produces a coarsely speckled pattern on the fluorescence ANA, and this is not so important either. We're going to skip over this. ANAs can also be detected by immunodiffusion, but we're not going to talk about that either. EIA has also come into use, but the ANAs are still the best. So EIA testing is also quantitative, it's less subjective, and it can be automated easily. But because these fluorescent patterns, they are pretty subjective and hard to read sometimes. We frequently have to go, hey, can you come look at this? I'm not really sure if I'm seeing coarsely speckled or finely speckled. Okay, so to recap, how are positive ANA tests confirmed? Well, we really didn't talk about confirmation, but these assays for specific antibodies using immunodiffusion, and if anti-Smith is positive, that means the patient has lupus. If anti-Smith is negative, can we rule out lupus? No, because anti-Smith is specific for lupus, but only found in 30% of lupus patients. So let's talk about that. So we've said that anti-Smith is diagnostic for lupus. Okay, but if the anti-Smith is negative, can we say that means the person doesn't have lupus? No, because although anti-Smith is diagnostic for lupus and specific, only 30% of the patients that have lupus have the anti-Smith antibody present. So you can see that diagnosing lupus is very complicated and the laboratory is very important. Okay, antiphospholipid antibodies are, we don't care about those, but they bind to phospholipid. I mean, again, man, just so many different things that your body can make antibodies to. Okay, the lupus anticoagulant is one of several types of antiphospholipid antibodies because it can prolong the PTT or the PT. Those are our coagulation tests. And the lupus anticoagulant may cause false positive results for syphilis. So as we get further into immunology and our knowledge of lab testing, we're going to learn that syphilis, pregnancy, old people, elderly, and the very young patients can cause problems with our immunology testing. So let's recap lupus. More common in women. The onset is middle age, 20 to 40. I wouldn't really call 20 middle age, but okay. There's a high titer of anti-Smith. That's common, but not in all. The butterfly rash, the LE cells, which is the neutrophil that has engulfed the antibody-coated nucleus of another neutrophil. We have antiphospholipid antibodies, may be drug-induced, may be affected by hormones and ultraviolet light, and the ANA may or may not be positive. Wow, that's so helpful. And there are also circulating immune complexes, which makes lupus which type of hypersensitivity? I believe that is type 3. Okay, now finally, moving on to a new disease. Rheumatoid arthritis is another example of a systemic autoimmune disease. It affects 1 to 3% of the U.S. population. Women are 3 times more likely than men, and again, the onset is about 20 to 40 years old. Even though our book says 30 to 50, just say, women, yay, we're going to more likely get this than men. Rheumatoid arthritis is a chronic, long-lasting, symmetric, and erosive arthritis of peripheral joints that can also cause multiple organs damage, like the heart and the lungs. In addition to a decline in functional ability, there's a reduced life expectancy. The diagnosis of rheumatoid arthritis is based on certain symptoms, and 4 of these symptoms must be present for 6 weeks or more for the diagnosis to be made. So now we're going to take a look at the key symptoms. So remember, 4 of these symptoms have to be present for a diagnosis of rheumatoid arthritis. Morning stiffness around the joints lasting at least an hour, so morning stiffness. swelling of the soft tissue around 3 or more joints, swelling of the finger or wrist joints, symmetric arthritis. So if you have index finger with morning stiffness and joint swelling, you got to have it in the other finger too. Subcutaneous nodules, a positive test for rheumatoid factor, and radiographic evidence of erosion in the joints of the hands, wrists, or both. So 4 of those symptoms have to be present. The earliest lesions in rheumatoid joints show an increase in cells lining the synovium. Also, you might have a finger or wrist twist called the swan neck finger in patients that have rheumatoid for a long time. Eventually their joints kind of just get frozen. And this is because there is continuous inflammation. All right, we don't really care about this, but this is pretty important. Approximately 75% of patients with rheumatoid arthritis have the rheumatoid factor antibody. And I think we've already talked about this, that it is most often the IgM class directed against the Fc portion of IgG. So it's an antibody directed against the Fc portion of IgG. However, this antibody is not specific for rheumatoid arthritis, and it's found in 5% of healthy patients and 10 to 20% of those over 65. So it's important to ask this question: why does rheumatoid factor rule in but not out rheumatoid arthritis? And that's because rheumatoid factor test is not specific, and 10% of rheumatoid arthritis patients are negative for the rheumatoid factor. Just can get so complicated. So let me say that again. Even though you have rheumatoid arthritis, 10% of the patients will be negative for rheumatoid factor. And there's a high false positive rate for rheumatoid factor as well. So 5% of people that don't have rheumatoid will be positive for rheumatoid factor. And if you're over 65, that number goes way up. In rheumatoid arthritis, IgM antibodies combine with IgG, and these immune complexes become deposited in the joints, resulting in a type 3 or immune complex hypersensitivity. You get complement complexes, the complement cascade begins, C3A and C3-5 are generated, and those are chemotactic factors that call neutrophils and macrophages to the area. And this is where you get the inflammation. Diagnosis of rheumatoid arthritis is made on the basis of a combination of clinical signs, X-ray findings, and lab testings. And rheumatoid factor is the antibody that is classically most often tested to make the initial diagnosis, although we know that's not going to be 100% accurate all the time. There are 2 types of agglutination tests for rheumatoid factor, and they have been developed, one using sheep red blood cells coated with IgG, and the other using latex particles coated with the same antigen. Agglutination tests detect only the IgM isotype found in about 75% of patients. So a negative rheumatoid factor result does not rule out the presence of rheumatoid arthritis. And we said that already. And we already also said that on the flip side, a positive rheumatoid factor test does not mean the patient has rheumatoid arthritis. Okay, we can do EIA testing for rheumatoid arthritis, and typically what we do is a CRP, that's a C-reactive protein, was just a general test for inflammation, and a sedimentation rate. And now those are much faster, but they are both elevated. Also, the level of complement components will be normal or increased, indicating increased synthesis. All right, now we're going to move on to autoimmune thyroid diseases, Hashimoto's thyroiditis, and Graves' disease. So Hashimoto's thyroiditis, you could have an antibody to the thyroglobulin hormone, and in Graves' disease, you have an autoantibody to the TSH receptor. Both diseases have very different symptoms, but they do share some antibodies, And both of these diseases and their autoantibodies interfere with thyroid function. So a little bit about the thyroid. The follicles inside the thyroid are filled with material called colloid. The primary constituent of colloid is thyroglobulin, and a large iodinated glycoprotein, which is the precursor of thyroid hormones, T3 and T4. So that's what's in those colloid. We don't really care about this. Well, if we want to know some endocrinology, this is important. So we have the TRH, thyrotropin releasing hormone, is released from the hypothalamus. It goes to the pituitary. The TSH is produced. That binds to receptors in the cell membrane of the thyroid gland, and the thyroid breaks down and produces T3 and T4, which is important in metabolism. Okay. These autoimmune responses to the thyroid seen in these diseases is based on genetic susceptibility partnered with environmental triggers. So genes associated with a predisposition to thyroid autoimmunity are divided into two groups. So just know that there's a genetic link to having these thyroid diseases. So first we're going to describe Hashimoto's thyroiditis, also known as chronic autoimmune thyroiditis. It's most often seen in middle-aged women. Like, we are just killing it, the middle-aged women with these autoimmune diseases. It can occur anywhere from childhood up to about 70 years of age. Patients with Hashimoto's develop a goiter, so they have this enlarged thyroid, so they have this large lumpy neck. They have hypothyroidism, so decreased thyroid hormone production, and thyroid autoantibodies. And this is treated with hormone replacement. The symptoms of Hashimoto's, so you have decreased thyroid production, you're going to have dry skin, decreased sweating, puffy face, pallor with a yellow tinge, weight gain, dry and brittle hair, and antibodies to thyroglobulin. So think about Hashimoto's is that you slow down. You're cold, you're slow, you gain weight. That is Hashimoto's. Now, Graves' disease is kind of the opposite. You have hyperthyroidism, antibodies to thyroid stimulating hormone. You do have enlarged goiter again, but you're nervous, you can't sleep, you're depressed, you lose weight, you're so hot, you're sweating, you have a rapid heartbeat, palpitations, you're breathless, you're tired, your heartbeat is weird, and you're restless, and you're all skinny with bug eyes. So, Graves speeds up. You're skinny, you're hot, you're nervous. All right, and you have bug eyes. The proper term is exophthalmos, is seen in approximately 35% of patients with Graves' disease. And the disease includes the antibodies against thyroid stimulating hormone receptor and antibodies to thyroid peroxidase. That's what's important. There are three major autoantibodies present to thyroglobulin, thyroid peroxidase, and TSH receptors. Antibodies to thyroglobulin are in 90% of patients with Hashimoto's thyroiditis, and healthy individuals may have a low titer of anti-thyroglobulin antibody. But in patients with Hashimoto's, the titer is considerably higher. All right, we're going to skip this. I'm going to let you read this. Okay. You can treat this with radioactive iodine to kill the thyroid in the for Graves' disease, and then you give hormone replacement to treat that. All right, next, the next disease is autoimmune diabetes mellitus, now termed type 1A diabetes. It's a chronic autoimmune disease. that occurs in genetically susceptible individuals as a result of environmental factors. 10% of patients with diabetes mellitus have the immune-mediated form of the disease. So what happens is there is insufficient insulin production caused by destruction of the beta cells of the pancreas, located in clusters called the islets of Langerhans. So the islets of Langerhans are clusters, and they have beta cells. All this is going on in the pancreas, and they make insulin. So for type 1A diabetes mellitus, you have an autoantibody that destroys the beta cells, and you can't make insulin. Okay, there are also environmental influences, and you end up with hyperglycemia, because what insulin does is insulin increases the intake of glucose by the red blood cells. So if you don't have enough insulin, then the glucose can't get into the red blood cells, and it stays in your bloodstream in the liquid portion, and then it can do crazy things to your brain and the rest of your body and deposit in your tissues and all kinds of things, leading to neuropathy. Like you lose the feeling in your fingers and toes, and you lose your eyesight. Okay, there is generalized inflammation that results, that helps destroy the beta cells of the islets of Langerhans. Antibodies can be detected, but that's not usually how we detect diabetes. The next disease is multiple sclerosis. It's an inflammatory autoimmune disease of the central nervous system, and it is characterized by lesions that form, called plaques, in the white matter of the brain and spinal cord. So what's happening is the spinal cord is covered by this protective myelin sheath of axons, and this myelin sheath is attacked by antibodies and begins to degrade and erode, which causes defective nerve impulses, and so these patients have bouts where they can't walk, and then all of a sudden they may be fine. Okay, so another combination of genetic and environmental factors is responsible for the development of multiple sclerosis. Damage to the tissue of the central nervous system can cause vision problems, weakness or diminished use of the limbs, arms and legs, locomotor incoordination, so that means they can't walk right or use their arms right, dizziness, their face may become droopy, and they may have sensory abnormalities like pins and needles that run down their spine and extremities, and also flashes of light seen on eye movement. So within these plaques that are being formed on the myelin sheath, T cells and macrophages predominate, and so they are believed to orchestrate the demyelination. So all this is just a different type of inflammation. So the antibody binds to the myelin membrane, and it can initiate the immune response, stimulating macrophages and phagocytes called microglial cells. So the cascade of immunologic events results in acute inflammation, injury to axons and glia. Hope y'all remember that from your A&P class. And eventually you get neurodegeneration because of this inflammation. Two of the most common tests for the diagnosis of multiple sclerosis are oligoclonal banding, which is a electrophoresis test, and the CSF or spinal fluid IgG index. So you get oligoclonal bands increased in the spinal fluid of patients with MS on protein electrophoresis that are not seen in the serum. And then you can also do some other testing, but for this intro class, we are not going to worry about that. Just know oligoclonal bands, electrophoresis, protein electrophoresis. Okay, the IgG index compares the amount of IgG in spinal fluid to that of serum. That's what that is for. And then the next test that we're going to talk about is myasthenia gravis. It's an autoimmune disease that affects the neuromuscular junction, and it's characterized by a weakness of the skeletal muscle. And there's the autoantibody produced here is an antibody mediated to damage acetylcholine receptors. So acetylcholine receptors are in our muscle junction, and that helps conduct muscle movement. And so these acetylcholine receptors get destroyed, and the muscle and nerve can't communicate. Early signs of myasthenia gravis are drooping eyelids. So some ladies may go and try to get plastic surgery to correct this problem, and that's not the problem. It's just that they have this myasthenia gravis. Other symptoms include difficulty speaking and chewing and swallowing. And I do know of a person that had myasthenia gravis, and one of the first symptoms was he had periods of time where he couldn't speak for a while, but the first thing that sent him to the hospital was the lack of swallowing. Respiratory muscle weakness occurs. It can be life-threatening if that happens. It's a slow progressive disease. It's often associated with other autoimmune diseases like lupus, rheumatoid arthritis, and pernicious anemia. So pernicious anemia is an autoimmune disease caused by antibodies to the parietal cells in the stomach, and parietal cells make hydrochloric acid, which helps digest your food. So in pernicious anemia, you may be getting plenty to eat, but your body is not absorbing any of the nutrients, and so that's causing a problem. And that is written out for you later on in the notes. All right. Oh, here it is. I did add this for you. So pernicious anemia, antiparietal cell antibodies cause decreased acid production. Nutrients can't be absorbed, and the symptoms are you have a lemon yellow, waxy pallor, a red beefy tongue, and you're tired. Okay, let's see. Almost the last disease that we're going to talk about is Goodpasture syndrome. And in Goodpastures, there's a presence of autoantibodies to glomerular, renal tubular, and alveolar basement membranes. The signs of renal or kidney involvement are microscopic hematuria, protein in the urine, decreased creatinine clearance, and increased BUN and creatinine. Now, finally, men get a turn. Males between 15 and 40 are the ones most often affected by this disease, and it often follows a viral infection. So that is Goodpastures, males 15 to 20. Addison's disease affects 1 in 100,000 people. It can happen at any age, and this is a problem with the adrenal glands not making enough cortisol or aldosterone. Addison's disease, a problem with the adrenal glands themselves. It's called primary adrenal insufficiency. And what happens is the body's immune system mistakenly attacks the adrenal glands and destroys the outer layer of glands. So why are cortisol and aldosterone important? Because cortisol helps the body respond to stress, regulates the body's use of protein, carbs, and fat, maintains blood pressure and cardiovascular function, and controls inflammation. Aldosterone helps regulate kidneys and the amount of salt and water in your body, and it helps maintain blood pressure. So when aldosterone is too low, your kidneys cannot keep your salt and water levels in balance, and this makes your blood pressure drop. So Addison's disease is the result of a problem with the adrenal glands themselves, and it's called primary adrenal insufficiency. And here's a nice table that includes all the diseases that we talked about, the autoimmune diseases, and the organ that's affected. And so it's important to note Addison's disease, adrenal gland, autoimmune hemolytic anemia. If this were a cold autoimmune hemolytic anemia, the most common antibody associated is the anti-big I. That's a capital I, and that's how we say it, anti-big I, and it attacks red blood cells. Pernicious anemia attacks the parietal cells or gastric cells of the stomach. Post-streptococcus infections, glomerulonephritis affects the kidney. Rheumatic fever affects the heart. Scleroderma connective tissue, Sjögren's syndrome, eyes and mouth, Hashimoto's, thyroid, Graves, thyroid, multiple sclerosis, the myelin sheath of the nerves, IDDM, insulin-dependent diabetes mellitus, the pancreas, rheumatoid arthritis, joints, lupus, joints and kidneys. And the final couple slides are about ANA patterns. So remember that homogeneous, there's a diffuse fluorescence, and that could be an antibody to double-stranded DNA or double DNA histone complex. So this is more of what it would look like. So the whole thing would be glowing. This would be speckled, peripheral, and nucleolar. So those are the four main patterns. And again, this is like a real life picture of what the cells look like under the microscope. So homogeneous, finely speckled, centromere, and nucleolar, although it is clumpy. And that concludes our autoimmunity lecture.